We will continue talking about respiratory distress syndrome in the form of case scenario. A male neonate was born at a gestational age of 34 weeks to a gravida 3 para 0 mother. The baby was born by cesarean section because of breech presentation and rupture of membranes of approximately 2 hours duration. He weighed 1700 grams and appeared vigorous with spontaneous respiration. The 1 minute and 5 minute Apgar scores were 7 and 9 respectively. This is the baby. 2 hours after admission to the neonatal intensive care unit, he develops tachypnea. His respiratory rate was more than 60 breaths per minute, with expiratory grunting and sternal and intercostal recessions. He was cyanosed in room air. Here we note the symptoms of RDS may develop minutes or hours after birth. Usually, the symptoms develop after 2 hours, 2 to 6 hours after birth. So what is the problem of this neonate? You can think. This neonate develops RDS. Why? Because there is risk factor, that is prematurity. And as we said, premature babies are more liable to develop RDS. How can we confirm the diagnosis of RDS? Definitely by chest X-ray. What are the findings on chest X-ray? The areas of collapse appear as diffuse reticulogranular mottling, and air in the major bronchi is constructed against the white background, a picture which is called air bronchogram on ground glass appearance. This chest X-ray shows a newborn baby who is premature with respiratory distress syndrome. As you notice, major bronchi are visible with air on a white background. Air bronchogram on ground glass appearance. This is another one. So, in a summary, the diagnosis of respiratory distress syndrome depends on, first, clinical picture. The onset usually shortly after birth or develop after a few hours, usually 4 or as we said 2 to 6 hours after birth. The signs and symptoms of respiratory distress: auscultation shows diminished air entry will be detected. Diminished air entry will be detected. Also by chest X-ray, as we said, air bronchogram on ground glass appearance. Other investigations really helpful for the management, not for the diagnosis, as blood gas analysis and serum electrolytes. What other possibilities you would think of as differential diagnosis? We always have to think of other possibilities rather than RDS, although he is premature or the child is premature. However, still we think of other possibilities. The first one is infection, that is the early group B streptococcal disease. How can we differentiate between infection and RDS? As the chest X-ray may be identical sometimes, by positive blood culture in early group B streptococcal disease. This is the key for the differentiation and for the diagnosis of infection. Gram-positive cocci in gastric or tracheal aspirate, in addition to the complete blood count, which shows marked neutropenia. Other differential Differential diagnosis includes transient tachypnea of the newborn, TTN. This condition occurs in the newborn baby, but however, they are usually term babies. So how to differentiate? They are usually large preterm or term infants. It usually affects the term infants. The signs and symptoms of respiratory distress occurs within 1 hour. That's to say immediately after birth with subcostal retraction, grunting, and cyanosis. However, they are not so severe, and the cyanosis is not prominent as that's seen in RDS. Most infants recover within 2 to 3 days, and chest X-ray findings are negative in transient tachypnea of the newborn. Other differential diagnosis is meconium aspiration. The meconium aspiration usually affects post-term babies, babies with intrauterine growth retardation. It does not occur in this condition. The meconium aspiration does not occur in the premature infants. Also, term babies with asphyxia. Here we have to differentiate between RDS and meconium aspiration, as both babies are term. However, the asphyxiated baby have no characteristic X-ray findings as seen in meconium aspiration, as we will see later. The chest X-ray findings is typical. This chest X-ray is typical for meconium aspiration. So we confirmed the diagnosis of RDS in this newborn baby. And now how would we treat him? The aim of our management is to maintain life, to support life of this child until adequate amount of surfactant is formed. And this usually occurs about 3 to 4 days after birth. This includes supportive measures, respiratory support as CPAP or ventilators, surfactant administration, close monitoring, and management of complications. To continue on our scenario, or this child who has been admitted with RDS to the neonatal intensive care unit. While you are observing the child in the neonatal intensive care unit, he develops increasing respiratory distress with no air entry on the right side on auscultation of the chest. This is a new event develops after 1 day of admission of the child to the neonatal care unit. What do you do for this child now? Immediately, one test should be done to this child, that is the chest X-ray. This is his chest X-ray. What did he develop? Think and look to the chest X-ray. Definitely you will know that this child develops pneumothorax. This is one of the complications of RDS. What other complications he may develop? He may develop bleeding, pulmonary and brain hemorrhage, bronchopulmonary dysplasia, retinopathy of prematurity, and later on learning disability. These three, the bronchopulmonary dysplasia, retinopathy of prematurity, learning disabilities, are remote complications, while the immediate complications that the child may develop, including the pneumothorax and the bleeding, pulmonary or intraventricular or brain hemorrhage. The child now is well, and you are counseling the mother and talking to the mother about discharging her with her child from hospital. However, the mother has some concerns and some questions. First, she asks, can this problem be predicted antenatally? She is afraid really to have another affected child. So she asks, can this problem be predicted antenatally? Definitely your response and your answer to this question should be yes. This is done by measuring the lecithin sphingomyelin ratio in the amniotic fluid and by ultrasonography. The lecithin sphingomyelin ratio is around 2 to 1, more at age of 35 weeks of gestation and more. If the ratio is less than this reading, this indicates lung immaturity. So, yes, the problem can be predicted antenatally by ultrasonography and by measuring the lecithin sphingomyelin ratio in the amniotic fluid. Another question she asks, how this problem could be prevented in my baby? So if she's got pregnant again and she asks, can we prevent my next baby to have RDS? Your response should be definitely yes, by preventing of prematurity, of predisposing factors for prematurity, antenatal glucocorticoid administration to the mother as dexamethasone given 48 to 72 hours before delivery at less than or at 32 weeks of gestation. And we can also prevent this condition by immediate administration of surfactant, one dose given immediately after birth to the premature baby, that is to say within the first 24 hours. This maneuver or this measure found to be effective in preventing the development of the signs and symptoms of prematurity. So we can prevent signs and symptoms of RDS. So we can prevent RDS in the premature baby by preventing premature delivery, antenatal glucocorticoid administration, and surfactant therapy. After finishing this lecture, I have a quiz for you. A newborn infant develops respiratory distress immediately after birth. No breath sounds are heard on the left side of the chest, but they are audible on the right side. An emergency chest X-ray is shown here. This is his chest X-ray. What do you see in this chest X-ray? And what is the diagnosis? Thank you for your listening.